Welcome to the Future of Dermatology podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SF Derm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SF Derm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology.
All right, thanks, Mitty, and thanks to Farah and everyone else who organized the meeting for having us come. This is an awesome venue. It's been great talk, great morning already so far. So today, to introduce myself, so I'm Dave Fiorentino. I work down the road at Stanford. I'm a dermatologist down there, and I see patients mostly with rheumatic skin disease. And we've been doing for the last, 15 years or something, work on looking at how we can use some of these auto-antibodies that we hear about clinically. How can we make use of them in the clinic? So I wanted to really focus on 3 auto-antibodies today in dermatomyositis and try to give you just a few take-home points about how you might use the information that we know now today for patient care. So these are my disclosures. I'm not really talking about treatments today, so they're not relevant. Okay, so these are the antibodies. If you think about the DM-specific antibodies today, 2024, there's six groups, and these are the 6 groups. The ones I want to talk about are going to be called TIF gamma, the second one MDA5, and the fourth one NXP2. That probably makes up 75% of your autoantibody patients. So it's going to be most of the patients that you're going to see in the clinic. So they divide patients into groups. There's also non-specific antibodies, right, that don't divide patients into groups. So they're not necessarily mutually exclusive, in other words. So these top 6 are sort of magical if you think about it, because you tend not to have more than one. And so that's telling us something pretty profound that we don't really understand yet. But what we do know is that if you look at patients within each serogroup, they look more like each other, right, than other DM patients that are in a different serogroup. So how can we use this? So I've been, for a long time, I've been thinking, what is the best way to use these antibodies in the clinic? And one way now I've realized is diagnostically, actually, not diagnosing to get an antibody test. I'm not talking about that. I'm talking about what we've learned about the phenotypes, that if you assemble enough non-specific things together into a picture, you can actually make a diagnosis of DM even when a patient doesn't come in with Gottron's papules, heliotrope rash, all that stuff. I'm actually not even going to talk about that today because we all know what that is. I want to talk about the stuff that's hard to diagnose. So what do I mean? So you have a patient who comes in, they got these funny red spots on their palms, right? Maybe not a lot of other stuff going on their skin. There's maybe some eyelid swelling, might even be unilateral, some puffy eyelids, maybe some hair loss, and pretty bad inflammatory joint pain. And that's it. And the patient walks in your door, and they may be going to you because maybe they're here for the rash. Maybe that's why they don't like. And I would argue that people may not, you might not really with this much information, you may be, I don't know what this is. It looks like something inflammatory, but each one of these things doesn't really tell me for sure what's going on. But if you put the whole picture together, that's very consistent, right, with a patient who has MDA5 antibodies. So you can make a diagnosis of dermatomyositis based on that, even without patients not having muscle weakness. There's no CK, they don't have heliotrope rash, etc. So I would argue that actually, if you know enough about these phenotypes, you're going to become a better diagnostician. And so just to review, MDA5, very important for the derms to know about, because the fact that it can be associated with really rapidly progressive interstitial lung disease and death. And so you want to be able to identify these features, the mucocutaneous features, to make sure you work them up to make sure that they don't have interstitial lung disease. And those features are the palmar papules, which I showed you a picture of. They can have ulceration on their skin, hair loss. Those are the 3 things that you want to be looking for. Other things in MDA5, those are the palmar papules. They can ulcerate and scab up like this, but they don't have to. But if they do that, they're usually pretty darn painful. So those patients are not going to be happy with those. And the other thing you can look for on the palms is sometimes it's kind of a reticulated erythema on the fingertips. So that sometimes is a giveaway. It's a very vascular phenotype. So sometimes even it can be on the trunk. So if you looked at that, you would not be thinking dermatomyositis, right? You'd be thinking, is this some sort of vasculitis or something? But in the right picture, these patients can have a really quite interesting vasculopathic signs. And this is just to show you that, yep, unilateral heliotrope rashes do occur. And this has been reported multiple times. So DM's not like this perfectly symmetric disease, unfortunately. So a lot of these patients who come in, you'll be like, someone told them they had a contact dermatitis or something because it was on one eye, it was swollen. But remember, it could be DM. Okay, what about another scenario? What about this? Patient comes in, you're in the hospital, doing your rounds, which I know you all do, patient, or maybe comes to your clinic, who's already got some, a tube in place, feeding tube. They're having a lot of trouble controlling their swallowing. They're aspirating, or their swallowing mechanism. They just find it very difficult to actually physically swallow food. They're complaining of a ton of muscle pain, maybe some tightness. Maybe weakness, but maybe not. Then maybe their main symptoms may be more pain and soreness. They have this funny swelling, not arthritis, but they have swelling peripherally, especially in their hands, feet, legs. And these patients don't have a history of swelling. They don't have bad veins or anything like that. And they have maybe a few nodules under their skin. Okay, and some of those nodules may or may not be firm. You may think, is that calcinosis? I'm not sure. Some of them may just be feel like almost like a subcutaneous nodule for which you would have a differential diagnosis, which included paniculitis. And this is a phenotype I think that people really don't appreciate. And the thing is, it's a very important one to start to think about. And this is what an NXP2 patient can look like, okay? These patients are actually form the group. There's a group called Dermatomyositis sine dermatitis with no dermatitis at all. And many of those patients have NXP2 antibodies. So they have dermatomyositis without having really any recognizable cutaneous symptoms, cutaneous signs. So again, I think this is a really important group. I think it gets missed a lot. This phenotype gets missed because the reason why it's important is these are the patients, in my experience, that end up being really, really, really difficult to control. They go in the hospital, you put them on steroids, you put them on IVIG, you put them on rituximab. They just don't get better. They can die of just respiratory failure, dysphagia, aspiration pneumonia. So these patients can have really, really bad outcomes, especially if their skin's ulcerating. So especially if you saw this kind of picture, they're saying my skin is swelling, it's my neck, almost my neck hurts. It's difficult to swallow. You see ulcers on their skin. I'm really worried about that patient. So you want to be aggressive early with that patient. Okay, so NXP2, think of it with myalgia, severe myalgia. So sometimes they just literally say, it's pain, my arm hurts. Dysphagia, and you may say, well, dysphagia happens all over in a lot of diseases. It does, but you start to put together these things. So they have really, really trouble swallowing. They get this swelling I mentioned, and then these nodules. And a lot of times the dermatologist will see them for these nodules. And I can't tell you how many patients I've had that they come with a skin biopsy, and the skin biopsy reads lupus paniculitis. And a lot of the times, I don't know why this is, but it reads fat necrosis. So you see a lot of reports of fat necrosis. So if you see that, that sometimes clues me in if I see some of these other features.
These are truncated replays from our original recorded sessions. Join us next year to get the full impact of the SF Derm experience.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.